And with that, I think we'll just I know we're, getting at the time, but we do have a couple questions. We just wanted to make sure that we'd address before we close out this Cafe Scientifique. So I don't know if we could bring everybody back, that would be. It's great to hear about this research on medication use, and especially for these new therapies or treatments coming on. So yeah, the evidence exists. I think Nazret and Shani also spoke to a lack of evidence. So we need lots of different evidence, but the treatments, the care models, and all of these different things is super, super important. So I might start just with the question that we had to skip over with Nazret and Shani, speaking about that, saying from somebody who said they're not, a person of color, but so they don't have that shared experience, but they have a very high pain tolerance since they were diagnosed with RA. And so they're wondering if you found ways to communicate with others, particularly healthcare professionals, about your pain, right? So I don't know if you have any recommendations there or have any experience with that you might wish to share.
I can speak to that a little bit. I think for one, it's definitely helpful if your healthcare practitioners know you, so they also know what your baseline is. Because the thing is that when you have a higher pain threshold, most likely you don't actually ask for help until you literally cannot manage your pain anymore. So right, you're at the very, very end where someone else might go in and ask for help at a time where they start experiencing pain. Most likely you've tolerated that pain until you literally can't manage. So if that's the only point where you're seeking help, chances are people are, your medical professionals are going to think that your pain is minimal since you're only now talking about it or seeking help for it. If you have people that know you, that already have an idea of your pain tolerance, your pain threshold, that's helpful. And sometimes that also means maybe asking, kind of preemptively, so before things reach a point where you're just you cannot tolerate it anymore, and that's why now you're asking for help. Asking for it early, even if you only even if at that point in time you're not actually taking advantage of all that pain management has to offer, because you know that you can tolerate for a little bit longer, but you still have, for one, it's been flagged with your medical professionals, and two, you've already started that conversation where you have started to experience the pain, even though you're not acting on it as yet. But I'm open, there's a lot of expertise here in this space, so I'm open to other feedback about what that might look like.
Sounds good. Yeah, I don't know if anyone else wanted to add in, Nazret maybe, or even Christina, based on your experiences.
Yeah, so my neighbor that was going through that high risk pregnancy with those uterine fibroids, she was in constant pain, and the pain was just beyond belief. She just had to endure it until she was ready to give birth, and that's all there was to it. And so, yeah, I mean, some may feel they don't have a choice but to persevere until the pregnancy is over. And I don't feel that like the healthcare providers are open to being more supportive, and that preventing the pain to continue on, and help the person that is pregnant with her pain situation. That's the common kind of belief amongst in our community. So less likely to trust themselves to reach out and to get a appropriate and supportive response. So it's a big problem.
It is. No, thank you for sharing that.
I
It's
will have to,
unfortunate.
sorry, thanks. I have to say that I really love, like, Dr. Nita and Mary's presentation. It felt maybe I understand so many things. Dr. Nia mentioned that the reason why they have to stop methotrexate, like we know why we have to stop methotrexate, but it's not only just to prevent the malformations, but also to see if your body can tolerate. And that was my situation. Once I was taken off methotrexate, I felt the most horrendous pain. It was similar to when I was diagnosed. And what I felt at that moment, it was that all the physicians were really hesitant to prescribe any medication. And just like Nasrid said, all I was given was Tylenol. And maybe they increased the prednisone. So I had to endure the pain for at least 3 months. And I wish I had really more answers to see how the pain management, but I certainly feel that we didn't have the tools to manage. And I don't know how it's now, but I didn't have them either.
Yeah, no, I think I did a similar thing, and even in terms of my own pregnancies, I ended up taking Tylenol to manage the pain that came out, because there wasn't really a lot of choices. And then especially with some of the non-steroidal anti-inflammatories, where at a certain point you can't take, right? So anyways, prednisone, steroids were it, right? It's unfortunate. I know we do need to do lots more to build the evidence base, I think, is what what I'm hearing, and to better support people during pregnancy. So it kind of brings me maybe to our next question from somebody. And I know, Netta, you had provided a bit of a comment in the chat, or response in the chat, about my partner and I are looking at family planning and taking methotrexates in addition to Cimzia, and they've received different answers about the methotrexate and before conceiving. And I don't know if you wanted to add anything else there in terms of the
Yeah,
washout time.
yeah. So I guess there's two things too. So if we're kind of going about it in a planned fashion, it would be my preference 3 months, even if possible, like 6 months, getting off of the methotrexate. This is not, again, so much about the methotrexate and how long it lasts in the system, but more because, as Christina mentioned, we want to make sure the patient doesn't flare going off the methotrexate. So usually, and I'm reflecting back on a case that I saw on Thursday, the patient was on methotrexate and hydroxychloroquine, doing fantastic. But I'm like, well, I know you're doing fantastic, but it's just not an option continuing methotrexate. And I'll talk about why. So I said, okay, well, she's like, I want to get pregnant as soon as possible. I was like, okay, well, so let's stop methotrexate today. We'll start you on sulfasalazine. It's going to take about a month to 6 weeks for the methotrexate to wash out of the system. It'll take about 6 weeks for the sulfasalazine to kick into the system. And then if you're on just taking hydroxychloroquine and sulfasalazine and they're not enough, we'll just escalate you to biologics. I just want to make sure that, again, you're going into pregnancy comfortable, pain-free, so you can continue that throughout the pregnancy. And as I think Christina mentioned, a lot of, and this is just, with regards to RA, most patients with RA get a little bit better in pregnancy. So if they were, they had like half an hour of stiffness, it might come down to like 10 minutes. But it's not the only, but pregnancy is not a way of controlling rheumatoid arthritis, one thing. And then the second thing, for those patients who don't go into pregnancy well controlled postpartum, they have a really bad flare. And again, I think Christina, you talked about this, right? So flare rates postpartum with rheumatoid arthritis are like 50 to 90% if patients don't have disease control. So, and then it's not only you have a baby to look after. And, all of us have kind of experienced this and how hard it can be, and then having the joint pain on top of that. But then there's other situation where, as Christina found herself in, it's like you didn't plan it, things happen. 50% of pregnancies are unplanned, and you accidentally conceive on methotrexate. So then the conversation is, what is the risk associated with the methotrexate and pregnancy? So there's not a lot of research around this, but what I'm finding more and more is that, so the big problem with the methotrexate, it can induce abortion. Like methotrexate is used to induce abortion, like 50 milligram IM. So if basically the best study that we have shows is that even if the baby to be, or so the embryo, is exposed to 1 dose of methotrexate, so this is roughly if you have taken 1 dose of methotrexate 2 weeks after your last menstrual period, assuming your last menstrual period, you have regular menses, the risk of miscarriage goes up to 40%. This is in comparison to the general population where the miscarriage rate is around 10 to 15%. So the risk is definitely increased. But what I see in and unfortunately, there's just nothing we can do about that. It doesn't matter how much folic acid we give the patient, just doesn't matter. But if somehow the embryo survives that risk of miscarriage, and as was the case again in you, Christina, sorry, I don't mean to put you on the spot. If the embryo is able to survive that 10 to 12 weeks and we have stopped the methotrexate right away, then it seems like it's okay. So a slightly higher rates of maybe having birth defects, around 7%, the background risk being around 3 to 5% for all comers, but it's not as bad as we thought. So again, some rheumatologists, even in this day and age, and definitely if they're not comfortable, they might, again, if they have a patient like Christina in front of them, they might say, yeah, you might want to think about abortion. But my tone has changed again, from seeing a lot of these is like, I'm sorry this happened. I know you don't feel good and I'm here to support you. Let's see how the next few weeks go. We do a 6 weeks ultrasound, we do a 10-week ultrasound, we do a little bit of prayer. Obviously we've stopped the methotrexate. And then if nothing happens, I'm like, okay, then we can just follow along. I refer the patient to maternal fetal medicine, but then the question becomes, okay, so now you're off the methotrexate, we're going to be flaring, so let's find another solution and get it on board before you start flaring.
Wow, that's a really complete, and there's a lot of nuance there. There's a lot of, important things to know, because I know this is one of the probably the biggest thing that I remember being told about this medication. So, but anyways, all of this does create a lot of uncertainty in people's lives. I think that's a key theme in terms of having to make all these different choices and decisions as things progress through the pregnancy. One last question here about, and I know this was put in the chat about, do you work, Netta, with other provinces to provide services to pregnant women in Alberta, for instance? And we talked about just some of the places, like we talked about Dr. Carl Laskin, whom Christina was fortunate to see, your own clinic. But anyways, I don't know what we know about how we could scale something like what you do, Netta, to other places. I think it's a really good point.
I mean, I can, if you tell me a province, I can usually tell like who in that province works, but usually it's like 1, maximum like 2 people like serving the province. I don't think other than us and Dr. Laskin in Toronto and maybe a couple other rheumatologists in Toronto, nobody like has called it that. Unfortunately, as it stands in Canada right now, most of us are clinicians, and we're not. I'm like a clinician scientist, but I'm not a clinician researcher. So it can be hard to do research without support, without money, without having money to hire research assistants, and statisticians and all that, which is why something like ARCS, Arthritis Research Canada, is so important for supporting researchers. And I'm participating with a gala next weekend, again, raising funds for arthritis research through Arthritis Society. So, again, invite your network to help contribute to those foundations and societies, so then they can in turn support us who want to do research. But yeah, the point being that because it can be labor intensive and you have to do this on top of your regular duties as a clinician, mom, whatever, administrator, sometimes there's not a lot of people just spread thin. I think even if they're interested, they just don't have the time, unfortunately.
Okay, sounds good and good to know. I almost wonder sometimes if we should pull up a list or put together a list if there's not too many anyways to help people navigate that. So yeah, no, thank you so much. And I know we're 15 minutes past the sort of official end time. I might just pass it over to you, Preet, because I think you were gonna, and I can follow up with all the participants too in terms of an evaluation survey and that sort of thing. There we go.
Hi everyone. So it's just like a post-session survey. If you could scan the QR code or click on the link in the chat, and it'll take about 5-ish minutes, less than 5 minutes. I think it should take about like 2-3 minutes to fill it out. If you could do that, that'd be great.
Thank you so much, Preet. And thank you so much to our panelists, to everybody. I've learned more about this topic just by listening here today. So I really appreciate everyone's effort to kind of pull together their points and their presentations and sharing that with us and being so generous with your time. And sharing sometimes not very easy lived experiences as well, with a particular call out to Christina and Shani and Nazret. These are difficult experiences, but I really do hope that it helps others understand what people are going through. And if we come to a better understanding, then one can only hope that we can improve the experiences of pregnant people with arthritis or Black communities. So thank you so much for that. And with that, I will let everyone continue with their day. I know it's a lovely weekend, finally some sun here in Ottawa. So I wish you all a great weekend, and thanks so much.